when you give progesterone to an endo patient, and I'm not talking about Slind or the synthetic progestins, I'm talking about BHRT, I'm talking about bioidentical. I've had so many patients that have failed oral contraceptives, but when you give them natural bioidentical micronized progesterone, all of a sudden it's like a weight is lifted because it properly opposes the estrogen that's running amok. If you take it orally, it converts into a neurosteroid. That is a very calming thing. It calms the system. And again, coming back to inflammation, what are those lesions doing, right? So you're giving something that is effectively calming the inflammation. That's what progesterone really does. She's the
Mm-hmm.
hero. But here's the thing, a lot of endo patients have progesterone resistance.
What's up, ladies? Welcome to the health class She Deserves, the show where we ditch outdated women's health myths and talk real bodies, real cycles, and real stories. I'm your host, Autumn Payon, and today we have episode number 3 in our endometriosis series with Elysara. If you missed the first 2 installments, go check out those episodes first. I'll link them in the show notes. Our next guest in the Elysara series is Jessica Doto, a board-certified adult nurse practitioner and the medical director for Elysara's Huntington and Ithaca facilities. Jessica has been practicing medicine since 1988 with a career that spans the highest intensity environments, from serving as an EMT and ER nurse to working as a flight nurse and ICU intensivist. Today, she brings that frontline experience into the world of functional medicine. Jessica's approach is centered on personalized, evidence-based care, combining advanced diagnostics, nutrition, lifestyle modifications, and natural therapies to support the body's innate ability to heal, especially for patients suffering with endometriosis. She's here to talk about why standard care often leaves endo patients hanging, the truth about hormone replacement therapy and IV infusions, and why her approach to healing involves looking at the body as a whole rather than just a collection of symptoms. Jessica, welcome to class.
Thank you so much.
I am so excited to have you here. Before we get into all of the amazing things we're going to talk about today for endometriosis, I'd just love to know a little bit more about your background and how you ended up at Elysara.
It was kind of interesting. So Nicoletta, who's the owner of the business side of Elysara, she and I were introduced by a friend that we had in common through one of the laser companies. We both had the same lasers in our office. And it was funny because we were using them along with IV therapy for skin health and ablative procedures. She and I just got along really, really great. And our common friend, Chris, he was just like, you and Nicoletta just seem so much alike.
Yeah.
And so then we ended up doing some webinars and a couple of podcast things and everything regarding skin health and IVs and other things that functional medicine, maybe doesn't 100% hit, kind of check off all the boxes. So we both found that we both did things differently in our experience in our practice, and it just kind of gelled. And then her medical director actually passed away very suddenly several years ago. I was at kind of a crossroads in my career, my life too. I had a practice already, but I was doing other things as well. It was just like a lot of things that were up in the air. And she called me and she said, Dr. Aquino suddenly passed away. She was devastated, but they were trying to keep the office open. So we emergently kind of credentialed me into the practice so they could start seeing patients again on Monday. So, and then from there, then we got through the closure of that practice, and there were multiple owners. And again, it was a very sudden thing. So I helped them bridge, basically, getting the patients through the process. And then Nicoletta deciding thereafter that she wanted to open again, but she really wanted to focus more on an all-encompassing, more of a women's health facility. Not that we don't see men, because we do. But, women have traditionally missed opportunity in the healthcare space. So not necessarily just doing like GYN work, but doing just a little bit of everything, from, HRT to skin, all the different stages of perimenopause, menopause, autoimmune diseases, which are huge. We do treat a lot of autoimmune patients. So it just kind of came full circle. And then when we decided to rebrand my office in Ithaca, and then we kind of put the two together. So it's all under one umbrella of Elysara. And I go back and forth basically between the two offices now.
Wow. Yeah. And I think that's really amazing because, like you said, the women's healthcare space has a lot lacking right now.
Yeah. I feel like in some ways we're moving the needle a little bit because
Hmm.
people were becoming more aware. I mean, just the fact that they finally took the black box warning off of estrogen took them forever to do
Hmm.
that. Like, why, we still have a long way to go, but there are a couple things that have happened of late in the medical community and also on the political side. And unfortunately, that does, politics impacts medicine, whether we like it or not. So there are some things that have shifted a little bit that I think will make it easier for women to have access to care. But there is still such a long way to go. There's not enough research. There's not enough studies. There is not enough of the
Hmm.
correctly dosed medications for women versus men. We're just still not there, as
Hmm.
humankind keeps evolving. We haven't evolved past that.
Hmm. Yes, absolutely. And there's a lot of gaps that need to be filled. And I know, one of the main things we're going to talk about today with endometriosis,
Mhm.
obviously, is this gap that Elysara aims to fill between surgery getting, because it's difficult enough. First of all, let's just recognize that it's difficult enough to even get a doctor to take you seriously and to get in to do a surgery, let alone with like an actual qualified specialist to
Yes.
do the correct surgery. All these things that as a patient we shouldn't really have to be like worrying about,
Yeah.
but we have to. And then, let's say you are privileged enough to like to get that experience, and then you're still kind of left with the what
hmm
next? What do we do next? What is, I guess, in a more general sense, what are you doing at Elysara to help fill that specific gap for endometriosis patients?
So we also, we've tried to partner with excision surgeons, not ablative surgeons, because we know that ablation is not the right path to take. Excision surgery is the gold standard, period, end of story. I will die on that hill. But, trying to find even the best of the excision surgeons with the right techniques in order to be able to care for endo patients, that's also difficult. And they're not easy to come by. Just because you do gynecologic surgery or some sort of gynecologic microsurgery doesn't mean that you do endometriosis. So it really is, it's a subspecialty within a subspecialty. So
Mhm.
that's a big part of it. The other piece is that there is no cure for this disease. It is a chronic disease that has no cure. There is treatment. There hasn't been great treatment. I think we at our two offices do. I'm not going to pat myself on the back, but I think we do it better because we address it's a systems disease. It is a neuroinflammatory systemic disease. It is not a gynecologic disease. So I think what we do is we first try to, when patients come through our service, we say to them, a lot of women that come to us, they come to us because they're having problems and pain and inflammation and everything, and they don't know what's wrong with them. And then we sit down and have a consultation. We say, "How were your periods your whole life? Did you have a lot of pain? Did you have not a lot of bleeding? Do you have a lot of allergies? Do you have a lot of sensitivities? Do you have hypermobile joints? Do you have like all these things that kind of tick off to us like, hey, you may be an undiagnosed endometriosis patient." So the 1 in 10, which is kind of been the classic number for the number of women, for every 10 women, there's one that has endometriosis. I feel like from what I see, it's probably closer to 4, maybe 5 and 10. I feel like
I
probably
believe it.
near 50% of the women that I see, and
Yeah.
I have seen thousands of patients over the years. I mean, I've been doing like care a long time. I can clock it now and say it's probably closer to at least 40%. Now, do I have the data to
Hmm.
back that up? No, because nobody's done a research study on it. So that's an ad hoc, observation on my part. But what ends up happening is there's a lot of women say, you know what, I felt terrible my whole life, and everybody just said suffer through it. And that's how they find out they have endometriosis. And we have patients that are in full blown menopause in their 60s and 70s sometimes and never knew, we're infertile and all of these things. And nobody ever, especially for women my age and older, it's very difficult because now you're menopausal, but the disease didn't go away. And I think that's the key. So when we talk about full-blown hysterectomy in young women, and when we talk about Lupron to shut off estrogen signaling in the ovaries, we talk about these things. Putting women into surgical menopause is not taking care of the disease. Are there women that qualify for full hysterectomy? Yes. When you have stage 4 deep infiltrating endometriosis, you have organs that are matted together. You have fibrosis, you have scar tissue. All of that has to be excised. And sometimes those organs are not salvageable because the disease has progressed so far. So does hysterectomy, is there a place for it? Absolutely 1,000%. But the thing is, we're trying to prevent women from getting to the point where they would need that. So our approach, is looking at the person as a whole system. And there are different phenotypes of endometriosis. There are some people who have, I'll call it endo light, and others that have basically life altering consequences and a lifetime of pain and misery and depression and medical gaslighting and all of it. So we see it kind of on all ends of the spectrum, but our core philosophy remains the same for all of these patients is we have to make a decision, a clinical decision about how we treat your symptoms, how to optimize you and get you to a surgeon for a surgical evaluation. Because if you don't take away the lesions, then you are missing a huge piece of the picture. This is not something that can just be managed medically. Part that we do, though, the medical management, is working on the inflammation and working on the optimization and the overall health of the patient so you can get into a surgery in the best shape possible and the healthiest way possible in a patient population that is generally very unhealthy because of their disease. So that's kind of like the forward piece of it. And then for patients who've had surgery and they say, you know what, I had excision surgery a year ago, I still have pain. I still have symptoms. I still have other things going on. Because here's the thing, surgery takes care of the existing lesions and fibrosis and all that, but your systemic response, the neuroinflammatory process behind endometriosis, was never addressed. So what we try to do then is address the neuroinflammation, and we have multiple ways that we do that and try to reverse some of that neuroinflammation so you can be in a better, happier place and then maybe prevent another surgery. We have endo patients that didn't have just one surgery. We have patients that have had 10 surgeries. My partner herself, Nicoletta, and I have permission to say this because she tells all the patients that she had 5 surgeries,
Hmm.
and had bowel complications and things like that. So that's another thing. Like endo is not, we look into the pelvic cavity, but there are so many women that end up with colostomies, diverting ileostomies, bladder prolapse, all these other things because there's so much scar tissue there. People that were told they have lumbar problems, but it's not. It's not the lumbar
Hmm.
problem. They have a lesion that's, behind the uterus, between the uterus and the rectum, backing up to the sacrum, and it's causing pain. And they have radicular pain too. So, they look at that big old nerve coming down the leg, and sometimes you will see endometriosis either around because endo likes nerves. It likes to make nerves, likes to make its own estrogen. It likes to make its own blood supply. It's almost, I view it as kind of like a new organ in your system that's building.
Hmm.
For example, when you're pregnant, right? You have your amniotic sac and everything, but you have a whole organ that grows that's going to sustain that baby, right? So it's the same thing, and it creates its own environment, all that. So endo does the same thing, and it likes nerves, it likes vascular supply, it likes all that. So when you see patients with lesions that are on the sciatic nerve, for example, these are the patients that were told they have back pain, go to physical therapy, all these things. So it's all of those things that if you don't address that, because when the system is inflamed for so long, even when you go and fix those parts, you still have to go back and do a hard reset.
Hmm. Yeah.
So
Yeah.
and then there's long-term management from there, because again,
Hmm.
like surgery is important, but surgery is a big trauma to go through as well. So if we can prevent somebody from needing another surgery because we've controlled lesion development and inflammation and things like that, then that's better for the patient, or at least spreading that time out further rather than having like boom, 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 a
Exactly.
surgery every year. Maybe it gets pushed out to 5 years if you do need another one. So that's the goal. It's the management of that in more novel and effective ways because there's good evidence on the physiology side for certain things, and that's the things that we do, but none of this stuff is approved, quote unquote, for endo.
Hmm. Love that analogy that you had, first of all, of saying it's, basically another organ creating its own environment. I think because we've reduced it for so long to just like this period disease or,
Hmm.
like you were saying with the hysterectomies, like just we demonize the uterus, we demonize the womb
Hmm.
culturally and in the medical system. And there's a lot, when you look into the history of modern medicine the past couple hundred years, it's built on very misogynistic principles in some respects. And it's concerning the amount that permeates into medical school today. Like from day one, it's what professionals are being trained in these kind of misogynistic ideas. And so I think if for people listening, if there's one thing you're going to take away from today's conversation, it's what you said a few minutes ago. It's not a gynecological disease. It's just not.
No, it is a neuroinflammatory disease, 1,000%.
Hmm. Hmm.
Everything, all the evidence that we've seen, and we see a lot of patients that Dr. Tamer Sechkin refers to as. He is probably in the top 5 endoexcision surgeons in the world. So we see, we do see some of his patients either preoperatively, postoperatively. We refer our patients to him and his practice because we know the quality of his care, and he understands what we do. He gets it. He gets it on the inflammation side. Like we have just started using microdose GLP-1s in postoperative patients. Not right away.
I've been hearing about
Takes
that.
a little time to get there because there's still some things that need to be fixed. GLP-1s are anti-inflammatory, on a lot of levels. And we could get into the weeds about GLPs and all the things that they do. This is just one little pocket.
Yeah.
But we know it works well in inflammation. We know it works well for patients with autoimmune diseases. We know it works well in chronic pain. We know it works well in substance use disorder. So there's all these things. But in an endo patient, you're reducing, GLP-1s keep your body from responding to a lot of these chemicals like cytokines and things like that are increasing the pain cycle. So that's, one new approach and everything. So we're just so happy that, we have a surgeon, that we can refer to that is on the same page as
Yeah.
us and understands that, okay, now, you do surgery, do all the work, clean everything up, give the patient like clean slate, as blank a canvas as you can get. And then we come in after that with our approaches. And our approaches, I would say, are very focused on the physiology of the lesions themselves, because we know lesions don't just stay in the pelvis. I have patients with cardiac lesions, with
Hmm.
endometriosis on their lungs, on liver, on skin. So endo isn't just sitting all in that one place. It starts there, and estrogen also gets demonized. And I think that's why women get put
Hmm.
on things like Lupron.
Hmm.
It's a
Yeah.
temporary fix, but it's only fixing one bit because, again, the lesions will make their own estrogen. Lupron is only going to shut down your estrogen that it hyper stimulates your pituitary gland and then shuts down your ovaries.
Yes. And I have spoken to patients who've done that, and they told, like, I spoke a couple of interviews ago. I was speaking with one of my friends, and she did I don't know if it was Lupron or something
Mhm.
similar, but she was like, I don't think I prefer the endo
Because
symptoms
you're
to
in the
this. Like,
chemical
it's,
menopause. And for anybody that knows anything about menopause, it's miserable.
yeah, it's not
I can attest to that. I went through early menopause.
right.
I started menopause. I was 40. Was 40, done,
Mm,
menopause. I'm 56 now. I've been on
mm,
HRT for 16 years already. Yeah.
wow.
Menopause is not easy to take. We have estrogen
Yeah.
receptors throughout our entire body, our brains, our bones, our everything. It's everywhere. We are saturated with it. So when you
Yeah.
take that away, you can't think straight. Your joints hurt. You have no sex drive. Your emotions are unstable. All of it. All of it. So you're
Hmm.
swapping one problem for another when you
Yes.
completely shut
Right.
down that system. And like your friend Matt, she goes, I'd rather have the endo than feel this bad. And for especially if you're a younger woman too. I mean, like, I don't want to say it's easier for older women, but like we know it's coming. But when you're young and you're forced into that, or you're told there's not another choice, that's upsetting to me because we know the physiology of women, of all humans. We need hormones to live.
Hmm.
Andropause in men, same thing. You talk to a man that has prostate surgery and then goes on a testosterone blocker, same thing. It's male
Yeah.
menopause, it's the same thing. I've had those patients too. So,
Yeah.
know how important it is for the hormones to be balanced. When you give progesterone to an endo patient, and I'm not talking about Slind or the synthetic progestins, I'm talking about BHRT, I'm talking about bioidentical, because the synthetic, I've had so many patients that have failed oral contraceptives that are
Hmm.
progesterone based. But when you give them natural bioidentical micronized progesterone, all of a sudden it's like a weight is lifted because it properly opposes the estrogen that's running amok. But what it also does is if you take it orally, it converts into a neurosteroid. That is a very calming thing. It calms the system. And again, coming back to inflammation, what are those lesions doing, right? So you're giving something that is effectively calming the inflammation. That's what progesterone really does. Like she's the real
Mm-hmm.
hero in the story. Progesterone
Yeah.
really shines. But here's the thing, a lot of endo patients have progesterone resistance. So they'll say to me, so we start
Okay.
very, very low dose. Okay. Standard dose of menopause is 100 milligrams at night before you go to sleep. Endo patients, we can't do that. A lot of times we have to do it either intravaginally or rectally, or if we start with an oral dose, we start with 25 or 50 milligrams, very low dose because of that heightened sensitivity. So that's the other piece of it too. As endo patients, every single one says the same thing. If you order that from me, you have to order half the dose. I'm sensitive to everything. I can't take medications. Every
Yeah.
medication bothers me. Everything makes me feel overstimulated. Everything makes my nervous system feel weird. So that's the other
Mm-hmm.
piece of endometriosis, and this is a part of that neuroinflammatory cascade, is mast cell activation. So endo lesions, like they put out a signal that says, "Hey, mast cells, come follow me. Come over here. Hey, we need some help." Mast cells come and aggregate then in and around the lesions. And mast cells like angiogenesis, they like nerve fibers. Okay. So then what they do is then they start secreting things like histamine
Mm-hmm.
you know, and then the lesions are putting out prostaglandins and CGRP and all of these other things that are causing this inflammatory. And it creates its own loop. It's a feed loop that
Mm-hmm.
has no interruption. So that kind of massive sensitivity that has been going on for some patients 10, 15, 20, 30 years, even when you remove the lesions, guess what? Every nerve in the body has still been affected. So what
Mm-hmm.
happens is you don't basically you can't understand then with me like, well, you had the surgery, you should be out of pain. Your nerve endings are still on fire.
Yeah.
The
Yeah.
imbalance is still there. That the whole imbalance is still there. So it's an interesting concept when you think about um and how do I fix it, right? It's like, what do I
Mm-hmm.
do about it? Well, what you need to do is look at each one of those factors that are being released in the body and how do you battle that? How do you battle inflammatory cascade? And that's basically and I can't tell you the number of patients that I say to them, I want you to take an H1 and an H2 agonist for a week, which is like Zyrtec and Pepsid. Okay. Every day
Mm-hmm.
for a week. 9 times out of 10, they tell me they feel better at the end of the week.
Wow.
Histamines, so the body, again, reacting to something all the time. Now, you need histamines in life because
Yes.
it's your body's telling you, oh, something's wrong. But when it's just like making its own all the time and just running away with you, then you feel miserable. Okay. So you're
Yeah.
never, so you have to be able to stabilize that signaling. You have to interrupt that cycle and you have to say, oh, how do we down regulate cytokines? Progesterone counters estrogen driven signaling, things like that, neural calming thing, all of these things that we
Mm-hmm.
practice works on each one of the, and because of the complexity of it, there are dozens of factors that are released, by endolesions. You have to kind of take them one at a time. And then you have to, there is some, testing the waters with patients. And because what's going to work for one doesn't always work for another one, depending on the
Exactly.
phenotype of endometriosis they have. So it's the complexity of it. I mean, I'm hoping that, our friends in like allergy and immunology, which are kind of, I'll say like the mast cell activation syndrome gurus, I think they probably have seen it in their practice and didn't realize that it was actually, a part of the endolesions. And I think that is something that's changing a little bit now. Uh,
Yes.
there are more patients that are coming, and when we talk about, like I say, have you had weird rashes you couldn't get rid of, food insensitivity,
Mm-hmm.
like
Mm-hmm.
all of these things that are all histamine related, chronically stuffy nose, ears, all
Mm-hmm.
that, you know what I mean? Low ferritin is also like so common in endometriosis, whether you're still bleeding from menses or not. you have suppression of your production, your storage of iron, and your usability of iron. So we see everybody's got low ferritins, right? And the reactivity of certain iron products with a patient that has MCAS is off the charts. So there are different types of iron infusions. Some are more reactive than others. Even patients that don't have a reactive system, it can have a bad reaction to an iron infusion. It's one of the higher,
Mhm.
kind of infusions.
Right.
And there are some that are completely not recommended if you have somebody with a lot of sensitivities. They'll say people who are allergy prone, but really what they're saying is people who are sensitive to histamine. So again, this histamine the body
Yeah.
constantly throwing all these factors out there because it's on fire all the time. So here we're trying to do a good thing, right? We want you to feel better. We're going to give you an iron infusion, a series of them, so we could rebuild your iron stores, hang on to them, give you vitamin C with that. You need vitamin C to convert it to usable iron, all of these things. And then what happens? You get muddied up because of those mast cells.
Mhm. Mhm.
So, and they
Yeah.
don't just disappear after you have surgery. They're still floating around. They're stuck to the nerves. They're stuck to the blood supply. That it's always there, And then if you have even a small burden of lesions after surgery, just a few popping up, it's still going to do the same thing.
Yeah. Yeah. Yeah, it's so multidisciplinary, and I love what you were saying before about kind of just breaking it down, taking it step by step, what's actually happening with endo, and then how can we kind of fight these things sort of individually. And, hopefully one day as we learn more and more about it, we'll have a bit of a more cohesive, so there's not so many different things to juggle at
Hmm.
once. But I think that for a lot of people listening, they're probably like, oh my God, like all of this is making sense now. All of this is coming together. I had no idea all of these things were related
Hmm.
because it really does. There are so many different things, like you were saying with the weird skin rashes. Like, I think that's something a lot of us experience. And
Yeah. And you're like, why is
it's
this
never
happening to me? Why do
traced
I
to
always have a
anything.
rash?
Yeah. And no one has answers. Everybody's just like, oh, you must just be sensitive,
And yeah, you
whatever.
are, but why? Yeah.
Exactly. But why
Yeah, exactly.
exactly?
It's always the why. And then you can eat a food one day and be fine with it. The next day you eat that food again, all of a sudden bloating,
Hmm.
itchy, everything feels terrible, right? That's another thing that
And
we hear a lot
yeah,
with patients. Like, I was fine. I used to be able to eat peaches. Now I
yes,
can't even look at a peach. I can't sit in the same room with that.
yes. Exactly, and for me too, cyclically, like, there are certain things that don't cause me any
Hmm.
problems at certain times of the
Hmm.
cycle, and then when I have a completely different hormonal profile at a different time in the cycle, it's like it
Totally.
upsets my stomach,
Hmm.
it makes my throat feel
Yep.
weird, like,
Totally.
it's just and you kinda just have to experiment with yourself,
Hmm.
use yourself as a little case study to figure out what
Hmm.
works. I think something else you were talking about that I think a lot of people really relate to is the progesterone
Hmm.
resistance, which I think is a really important part of it that not enough people talk about or realize is a thing
Hmm.
because, when we first start going down the journey of trying to figure out what the hell's wrong with
Hmm.
us, a lot of times you get blood tests taken and everything's normal and all of your hormone levels are quote unquote normal.
You look good on
And you're
paper.
like, right. And in your luteal phase, when you're making progesterone, you are supposed to, like you said, like progesterone has anxiolytic effects. Like
Hmm.
it is supposed to make you feel good and calm and reduce stress.
Hmm.
But a lot of us feel super activated in our luteal
Yep.
phase instead. It's like the opposite. And we're like, why is that
Yes.
happening? And I think that's a really, really important part of it is just because you have the progesterone doesn't mean it's actually
Being
being
used or utilized.
right.
And that's a key issue too. And that's why we find that a lot of our patients respond very well to a very low dose estrogen patch along with a progesterone. And you would think like, well, you're not in menopause, why would you need that? But the constant steady level of estrogen instead of the spikes. And that's what happens with the
Mhm.
lesions is you're spiking estrogen and it's throwing the system off. So when you have a constant, very tiny little baby dose in there, and then you have the progesterone because you need the progesterone to oppose that estrogen, you want to make sure that the uterine lining is not going to get thickened and then we're not going to cause more bleeding and things like that. But, people have that kind of paradoxic reaction to it sometimes. So like, oh my God, I took progesterone because a lot of these patients have gotten dosed with progesterone the same way that it would have been dosed if you were a menopause or a perimenopause patient. So the approach really has to be different. And the delivery of the medication as well. Like we have some patients that we give them oral micronized progesterone, which look like kind of like little gumballs. You can actually use those intravaginally and rectally, Rectally is going to give you more of a systemic response. Intravaginally is going to be local kind of calming in the pelvis. So, and there's always topical as well, cream. So a lot of patients don't do well when they take it orally and have to go through that first pass metabolism with that neurosteroid conversion to the pregnenolone. It makes them feel drunk in the morning, or agitated all night and then sleepy in the morning, so there's a lot of things that we take into, but when it's more of a transdermal application, patients usually tolerate it better because you're not going through first pass metabolism in the liver.
Hmm. Yeah, and you were touching on this a little bit before, but when you were talking about kind of this fear-based narrative around estrogen, what do you have to say to people listening who are like, "Wait, I was told like
It's an
endometriosis is
driven
estrogen
driven
driven. I
disease.
was told I could never have it." Yeah, what do you have to say to people who are just really confused about that?
Yeah, and I think it's something that even a lot of providers don't understand, but you have to look at it from the perspective of you have an irresponsible, out of control system spiking estrogen, but it's local estrogen. It's not like the good estrogen that you need all over the place. It's creating estrogen that it needs to live. Okay. So when you have the local proliferation of that, that causes inflammation. But when you completely shut down estrogen systemically, that also causes inflammation. Hello, rock and a hard place, right? But if you give a tiny dose of systemic estrogen, it offsets the reactive phase because estrogen is, when it's balanced, anti-inflammatory. So when you're
Which is
giving,
probably shocking for some
yeah,
people to
and I
hear.
know
It's never the
it seems like
narrative.
completely counterintuitive, but when we put patients, so think about it even from a birth control perspective. If you have a combo pill that's a synthetic estrogen plus a synthetic progesterone, okay, some patients do okay, and that some people have been on all different kinds of synthetics. They try 10 different types of OCPs. Nothing works for them because they were all based on synthetic products. The body doesn't recognize the synthetic products intuitively, and the uptake of it just doesn't, just for some patients especially. And that's why even women without endo, you say, oh my God, I was put on oral birth control and I lost my mind. I gained weight. I got bloated. I was depressed. I was hysterical. Because it's a synthetic and because you're suppressing the estrogen so much so you don't ovulate, right? So it makes you
Mhm.
crazy. So we do have these conversations with patients and say, okay, listen, we're going to take you off your OCP. Or if Slimed is another one that, and a lot of, here's the other thing, a lot of patients during surgery get an IUD. So,
Mhm.
and then they're trying to deal with that as well. And I haven't really I've seen very few patients do well on those therapies in particular. I have probably 5 that I can count of late that actually did okay on a synthetic birth control and an IUD. I have more patients that are screaming to rip those IUDs out, and we send them to have them taken out all the
Mhm.
time, and they feel better. And then we do
Yeah.
bioidentical, and, it takes a little time, microdosing of that too, looking at the levels, looking at the balance, comparing that to the symptoms, all of that. And all hormone balancing is all about agonist and opposition. So it's when one is high, the other one is low. When one is low, it's topsy-turvy. I mean, endocrine is an incredibly complicated system. So when we look at all of these things for these patients in particular, they're so fearful. They're like, no, my doctor told me no estrogen, no estrogen. And I'm like, let's just do this in a really careful, balanced way because you were on an estrogen based, birth control. And I know that did you dirty, but
Yeah.
we're going to try something different. And then also emphasizing that this is not birth control because we're not suppressing ovulation. And that's another
Mhm.
thing to take into consideration is a lot of these women are going to try to conceive at some point, and they are trying to
Mhm.
preserve their fertility. So we're trying to do things that are going to be, an approach to balancing that hormone system, preventing the lesions from, going out of control. And there's a lot of things that we do with that. You know, antihistamines, yes, but reducing the systemic inflammation comes in many different pockets. A lot of the IVs that we do, things like N-acetylcysteine. There's studies about N-acetylcysteine and endometriosis and reducing pain because it reduces your reactive oxidative stress, basically. So, and acetylcysteine works wonders, for dampening that arm of that loop, in the
Mm-hmm.
process. So
Right.
that's just that's another pocket. So you have the hormone pocket, you have the pain signaling pocket. Blocking histamine is going to help you, when you have too much histamine, it causes vascular leak, it causes amplification of those pain signals, things like that. So
Mm-hmm.
when we start to interrupt these things one by one by one and start peeling away, and everybody is different when it comes to which kind of inflammatory cytokines that they have more of than others. We have some patients that are very high in TNF alpha, for example, and other ones that are really high in interleukin 6. So how do we manage that? We try to have therapies that address those in particular. It's so we have to, we have to address what we see. It's a chronic
Mm-hmm.
signaling disorder. So we have to look, we have to address what we say, and then say, okay, we're going to try this with you. Let's see how you do here. And then we have to have that kind of that trust and that contract with the patient to say, let us do this. I know you feel like you've done everything, and as yourself, endo patients have seen 10, 20, 30, 40 doctors, 40 providers, over the years trying to get an answer to that. They go to cardiovascular, they go to nephrology, they go to urology, bladder issues, they go, so there's a lot of different specialists involved. And those specialists we find are not connecting the dots. They're not seeing that it's just the one disease that's actually causing all of those things. GI
Mm-hmm.
and urology, I feel like I'm like, oh my gosh, there's so much GI
Yeah.
no
Yeah.
patients, right? And there's rectal endo, which is a horrible thing to have chronic constipation, things like that. Again, GI looks at it like, well, your colonoscopy was normal. I didn't see anything because they're not looking. You can't see endo lesions when you go with it. So
Right. Yes. And then they say IBS, and it's like, what is IBS? It's just a description of what's going on.
IBS is a symptom of another process. It has somehow become a diagnosis.
Mhm.
I almost have to laugh at that. I'm like, IBS is not a diagnosis. It's a symptom of something else that's gone wrong.
And that's how I've always felt, but I'm not a medical professional, so I always feel weird saying it, but I'm like,
Mhm.
I'm just common sense here. IBS does not sound like a diagnosis to me. It sounds like a description of a
It is.
symptom.
It's just
Yeah.
describing what your body is doing, but why is it doing it?
Mhm.
And they can't just say
Exactly.
everything is idiopathic. Yeah, because that
Mhm.
that doesn't wash with me. There's always something,
Mhm.
the gut brain axis is it's there.
Mhm.
Okay. The HPA axis we know is there, all of the gut brain skin axis is there. There are again neurohormone signaling pathways that connect your brain to your gut to your pelvis, it's all connected. I mean, we're not, like they treat everything as disparate, as its own little pocket, not realizing that it's kind of like, when they talk about like what is it, the mycelium in the ground underneath trees that help trees communicate, right? You
Mhm.
have all
Yeah.
this fungi basically that's under the ground that signals to trees in their roots to communicate. You have to start looking at, our version of that and these signaling pathways, and
Yeah.
it follows nerves and it follows blood supply. Those are like the two big ones because you have nerves everywhere in your body and you have blood supply everywhere in your
Right.
body. So that
Yeah.
carries to every system and every organ in the body as well. So we have to start looking at those pathways that are getting hijacked because of the disease. It's just that the endo lesions are just hijacking
Yeah.
everything. But that pain response, it's in the pathway. It's there. We know that. We know they travel in those same lanes. So it's interesting when you look at medications. I mean, we kind of call them like repurposed meds, a medication that was created for one thing. Now we use it for something else. But we
Right.
see the correlation with a lot of, and a lot of endo patients have migraine, you know,
Mhm. Yeah.
again, brains on fire all
Definitely.
the time. So I find it,
Yes.
interesting when we start to look at these things like migraine medications, like the GLPs, like other things, because they all run on the same pathways. So it would make sense to tackle those things with, so there are certain medications that, and because people think I do functional medicine, I'm like, oh, just take a supplement and nothing allopathic and everything. And that is the furthest thing from the truth with me. Like I said, I'm ICU intensivist all the way. Their medication keeps you alive, and it is called for so many things. Like when a patient has an infection, I'm not going to say to them, you know, let's take a let's just take vitamin
Trying to
C while you have a
supplement, yeah.
raging bladder infection that's going to
Right.
give you sepsis. No,
No.
no, 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 we're not going to do that. So, so
Yeah.
I believe in the use of medications being appropriately used for endometriosis.
And surgery, like you
And
said, too.
surgery,
Surgery
yes,
is
have the
necessary
surgery,
to remove.
clean it all up, get rid of it, because those endo lesions are only going to turn into fibrosis later. And that's when we start to see the matting of the tissues and the organs sticking together, organs being matted to the peritoneum, basically having a frozen pelvis because everything is just locked together in scar tissue. So every time a patient tries to move, they can't. It causes pain because none of the organs are sliding around in there. All your organs are supposed to be mobile enough and slide around in space. And you have fluids in between. When everything is matted together, it's like one giant scar.
Yeah. Yeah. And yeah, I can imagine it is not comfortable. And then you go to the doctor and they're like, nope, everything's fine.
Yeah.
And then you just think you're
Yeah.
insane.
Yeah.
Yeah. It's,
So and like you said, the misogyny of medicine, the chronic women should stop complaining. Periods are supposed to be painful. Women have better endurance. I love this one. Women have better endurance than men because they give birth. Yeah, we have higher pain thresholds. So if an endometriosis patient is telling you they're in pain physiologically, if that was a man, he'd be in the hospital. And this is a woman who
yeah,
has to still get up
exactly.
and go to work every day and take care of their
Hmm.
family or go to school or do whatever, live their life. So
Yes.
if they're saying the pain is bad, can you imagine, what it would be, how
Yeah.
amplified it is?
And I have women in my TikTok comments all the time that are like, I would rather give birth once a month than deal with
Mhm.
endometriosis because they're like, when I was in childbirth, the doctor thought something was like wrong with me, or they didn't believe that I was about to give birth because my contractions didn't hurt.
Yeah.
They were like, I was up and just, it was like a
Up,
normal day
up,
for
up and
me.
walking. Meantime, 10
Yeah.
centimeters, everything is happening. No,
Yeah.
we're
Right. Exactly. Cause they're like, my endometriosis pain is so much
Mhm.
worse than what I felt during childbirth. I'm like, that's insane. And the fact that we're not taking that pain seriously is actually crazy. Like, there's no other reason for it other than the misogyny.
Exactly. And women's pain is never taken seriously. I mean, ACOG just put out, which is the American College of Obstetricians and Gynecologists, just put out a paper about endometrial biopsies. Traditionally, if you're a postmenopausal woman and you have bleeding, everybody panics over some sort of endometrial cancer. And they're like, you have to have an endometrial biopsy. But if you do a transvaginal ultrasound and you see the lining of the uterus is thin, it's not hypertrophied, then why would you need to do that? It's a hormone
Mhm.
imbalance. And unless somebody's super high risk for whatever reason, family, this, that, whatever, previous cancer, whatever you want, there's many things, but an individualized approach. So it is really important. So then everybody they say, okay, you need an endometrial biopsy. Well, it is very hard to get the endometrial tissue when the lining is very, very thin. It's a blind biopsy. So this is why you have these inconclusive biopsies. And they do them in the office and they don't give pain medication.
Oh my God.
As a rule, it's not a recommendation. I mean, to give, even a Tylenol, or that sometimes they'll say to patients, oh, well,
Jeez.
take an NSAID before you come in or something like that. No pain control, no sedation, nothing. And I'm like, well, gee, if you were putting a dilator in my cervix and then going up into my uterus and then taking a clipping, you think I'm not going to feel that?
That's insane. And
So,
well,
and
and
now
with IUDs too, no pain
exactly.
medications.
So, so it's the same thing. And you have women who go to the ER because they're in so much pain, and then they're labeled as drug seeking
Hmm. Yeah.
because then
Yeah.
their pain
Yeah.
thresholds too. It's going to take more to get them out of pain. So they're actually going to be able to take, sometimes in that respect, higher doses of pain medication to try to calm that down because of structurally what's been happening in their physiology. So then they get labeled a drug seeker. And pain is real. It is a real thing. And yes, we have to be judicious about what we prescribe. I think appropriate prescribing of what should work for that patient should be, that's a conversation between you and your provider. We shouldn't throw narcotics at people, obviously, just willy-nilly. But there is a time, and again, regular medicine, there's a time and place for everything. So I think we need to get to a place where we start believing women when they say, I'm sick. There
Hmm.
is something wrong. I don't care that the labs are normal. Why do I have this pain? Why do I have this bleeding? Why do I have this rash? Why can't I eat food anymore? Why do I constantly have GERD? Why do my ankles swell? Why do I have brain fog? Why do I all of these things that they have all the time? And then nobody says to them, like, well, we don't think you have endo. It's like, what, how could you even say that? Why wouldn't you even, or they get told they have
Completely
PCOS and
misinformed.
their ovaries are not, looking like clusters of
Yeah,
grapes, which is truly what PCOS looks
right.
like. So that's the other thing. They go into a fallback position of some other disease that the patient just doesn't have.
So it's just so ridiculous, honestly, when you come down to it. And I speak with so many different women online and, hear a lot of their stories. And it's just so appalling, honestly, some of the things that we have to deal with as women in the healthcare system. But that's why, pl- clinics such as Elysara are so important and so necessary. And I hope to see, a rise of more people looking at medicine this way of like you're like true holistic medicine is not just, the more naturopathic stuff, and it's not just conventional modern medicine. It's holistic. It's
It's a
both of them.
combination. That's why we have
And it's
so many
individual for
different
each patient.
services available in our office too, because you think about it, like we have pelvic floor therapists, we have a chiropractor, we have a Reiki specialist, we have, life coach, we have trauma informed care, that
Hmm.
comes at different levels and is
Yes.
applicable to each patient at different stage of her life when it's needed. So we don't say that you don't come into the practice and say, okay, we're going to set you up with life coach, chiropractor, this, that, 94 IVs. And it's not like that. You look at the patient and say,
Hmm.
how would you benefit? And so there's something outside of this because of the trauma that you would benefit from. Because here's the other thing. Sick people also have traumatic experiences. So
Hmm.
now you take somebody, who maybe was sexually assaulted at some point in their life, and then you tell them they have to go for pelvic floor therapy. That's going to be a triggering event.
Hmm.
So then how do we deal with that patient? Because we need to give her the care that she needs, but we have to get her into the right place so she can accept that. And because of her
Yeah.
trauma, that may be difficult for her. So how do we handle that? So that's the other piece of this, is that we have to look at people that their entire history, there are things that have been happening in their life the whole time that they've had this disease. And if that hasn't been addressed either, then it's a huge fallout in medicine. And I warn my colleagues of this constantly, that if you are not having these conversations with your female patients and your male patients, but obviously female patients, we know assault patterns are much higher. If you're not having these conversations and doing right by your patient, and I'm calling out primary care, I'm calling out
Yeah.
OBGYN, I'm calling out our social worker friends, I'm calling out psychiatry, all of it, because it is your responsibility to take that into consideration when you're treating a patient for something that is a physical manifestation of that trauma.
Yes. Yeah. It's so important. And I'm so glad you said that because it's not talked about enough. And like I said, some of the stories that I hear from patients, it's just complete lack of consent in healthcare. It's like just because somebody came into your office seeking health doesn't mean that you can just touch them whenever and wherever you would
Exactly.
like. That's not at all the agreement when a patient walks into your office. And yeah, it's a really important thing to talk about. And I think that trauma informed care, like while it's like really great that it's getting more attention now, I feel like it should just be the standard,
Hmm.
you know, with the rates of assault
Yeah.
that exist. And that's a whole other,
Yeah, and
that
we can
should
talk
be
about that
fixed.
for hours on end as
First
well.
of all, yeah,
Exactly.
right. That, that would be the root of the problem, but we aren't God. So there's only so much that we can do. But yeah, that's a really important
But
part of healthcare. So I'm glad that you're talking
yeah,
about it.
absolutely. Because, I mean, and I have had in my practice women who get labeled non-compliant because they can't get through a pelvic exam.
Mm, mhm,
And I'm like, but,
yeah.
like, do you need to be doing all the things to ensure that you care for that patient? You have to ask yourself why. Why is it
Yeah.
that, is it pain? Okay. Because a lot of times it's pain. Is it emotional pain? Is it like, what is the reason for it? But I had a patient come in, she goes, yeah, she goes, my gynecologist fired me from her practice because she said I was non-compliant because I couldn't get through the pelvic exam that day. And she was a stage 4 endo patient.
My goodness.
And I'm like, of course you're not going to get a speculum in her, like,
Right.
she's telling you she has dyspareunia. She has pain with sex. She's not been able to have sex with her partner, in a year because
Mhm.
she's in so much pain. And then you're going to sit there and say, okay, well, we're going to introduce something into your vagina that, and you're going to just expect that
Mhm.
that's going to feel okay. It doesn't, So when she declined it, the doctor got mad and basically told her that you should go find another practice to go to if you're not going to let me do my job.
And yeah, we're like that ego. I don't
Yeah.
see how it's conducive to a good doctor-patient relationship.
It's not. It's not.
No.
Trust is huge,
Mhm.
and it's for any disease too. We have a patient right now that actually has a really wonderful cardiologist, and we're so excited because her cardiologist is actually, out of all the doctors she's seen, is the only one who's really pulling for her. Cardiology and neurology are like, hey, has anybody talked about your endometriosis and your POTS and your dysautonomia and
Right.
your all of your neurologic and cardiovascular issues that you're having, issues with blood pressure, all these things, and they're the ones who are, so I'm like, thank God, somebody is listening. And I would like to see more of, my colleagues in medicine, especially in specialties, saying,
Mhm.
hey, I know you have this diagnosis and the symptom that you're having in this other system. Maybe it's connected. Can we have a conversation about that? So I think it's incumbent upon us, just like you would say, if somebody has diabetes, see, to me, this is like medicine 101, right? If somebody walks in, they have
Mhm.
a chronic diabetic issue. Maybe they have neuropathy in their feet. Maybe they don't know they have diabetes. Or maybe they were diagnosed with diabetes and didn't do anything about it, and now their feet hurt. You're going to say to them, well, we have a diagnosis of diabetes. Maybe we have some neuropathy secondary to the diabetes and uncontrolled sugar. That's just a natural progression because we know that's what happens when one of the things that could potentially happen when your diabetes is out of control, when your sugar is out of control. So why wouldn't we apply the same approach to, you have a disease that affects everything? Diabetes affects every system in the body too. So
Right.
you have a disease that affects every system in the body. And when you come in complaining all the time of this one thing over time, over time, over time, why aren't they making the connection back to a systemic disease that they have? But it also comes back to, too many people think it's just a gynecologic problem.
Exactly. Exactly, and that's, like, really, I think, at the root of a lot of the issues that we deal with in healthcare is that it's still being taught at, like, God, I saw a video the other day where an endo creator came on and said her brother's in med school and they were in their OBGYN portion,
Rotation.
whatever, and were learning, quote unquote, about
Mhm.
endometriosis. And she like went through a list of some of the things that he sent her about the things that they were learning. And it was just complete factually incorrect information. And I was like, I knew it was bad, but I was like, it is so much worse than
Yeah, if
I
that's the
thought
organized
it was.
curriculum and for that ACGME has approved for a medical school to go,
Mm,
then yeah, they need to be updating. They do.
yeah.
But again, you don't learn
Yes.
about menopause when you go through a gynecology fellowship, when you go through OBGYN. They don't talk about menopause. They're like, okay, you stop
It's
menstruating, that's it.
insane. That's
It's
insane.
not like a part of it. It's just like, yes, okay, then that's the
Right.
next stage in a woman's life and she's in menopause. Okay, that's it.
Well, and that's why I always applaud Gen X because I think that there are so many incredible women speaking about menopause. It's like the first, and obviously, the age of the internet has helped so much,
Mhm.
but there are so many people in Gen X that are speaking out about menopause and what it was like for them and how they felt completely blindsided and how their mom never talked about it. And it was just this taboo subject and they thought that they were like losing their mind or like literally dying because the effects of it are that intense and they're like we need to be talking about this. So I always am grateful because I know that by the time I get to that age I will be much better prepared
Mhm.
than my mother's generation, the
Yeah,
generations
and
before her.
knowledge is power. When you have when the expectation is set and you know that there's a path you should follow, that transition becomes easier.
Mhm.
When you know that that path is in front of you, but when you know there are things that can be done to make it better, to help you through that transition into that point in your life,
Yeah.
and being a Gen X woman, I mean, I've seen that full gamut. That's our generation. We've seen a huge shift in
Yeah.
technology and medicine and just everything, and but we suffered through lack of women's health. We also
Yes.
were the first generation, though, that I was born basically knowing that, when Roe v. Wade was passed, I never had to worry about me not being able
Mhm.
to get an abortion if I needed that, if I needed to terminate
Mhm.
a pregnancy. That was never a thought in my head because my generation grew up with Roe v. Wade. So
Yeah.
for us to see this rollback in women's healthcare, and abortion is healthcare, and that's the second
Mhm.
hill I will die on. Abortion is healthcare.
Yeah.
It is needed.
Full stop.
We never had to worry about that. And when that
Mhm.
happened, I was like, my mind was blown because they are rolling back the clock on strides
Mhm.
that have been made in women's healthcare. Abortion keeps women alive. Abortion keeps women alive so they can try to have a child when they're ready, or
Yes.
I mean, it's mind boggling to me. So for us, like you said, our generation, this is why our generation is speaking out about all of these things in women's health. And a lot of us have endometriosis and never knew it,
Yeah. Never got diagnosed. Yep.
never got that diagnosis, you know? So
Mhm.
it's crazy when I think about it. Hopefully my generation, hopefully we are teaching our daughters that to not accept that. And that is something I know with my daughter. And my daughter's going to be 28 years old. Growing up with a person of medicine in your house is a blessing and a curse. But she said to me, she goes, what, if you weren't there advocating for me, she said, and helping me through this, she said, I think about all the people who don't have that advocate, that knowledgeable person in their house, in their life, in their sphere, how they just fall off the cliff. She goes, you are in my corner. You know everything there is to know about this. She's like, and you got me through this. She said, but I can't tell you the number of women my age that don't have that didn't have that, and horrible things happen to them as a result.
Yes, it's so true. My mom's not she's actually in medicine now, she's an ultrasound tech, but when I was growing up, she wasn't,
Hmm.
and but she was still just a an amazing advocate for us and just didn't she did not care if people thought that she was being
Hmm.
paranoid or whatever. She was like, "I don't care. It doesn't matter
Hmm.
what they think. We need to get answers for
Hmm.
this." And so I always say, like, I'll bring her to if I'm meeting with a new doctor or
Hmm.
something, if she's able to come to the appointment
We do
because
that a
she asks the
lot.
good questions and
We have
yeah,
a
she knows what I need to
Mhm.
know.
Yeah,
Yeah.
we have a lot of moms who come in with their
Mhm.
daughters, and then we find
Yeah.
out I have 3 generations of endo patients right now. It's the grandmother, the mother, and the granddaughter, the daughter, all 3 of them.
Wow.
So, yeah. I mean, doesn't that doesn't I mean, it blows my mind sometimes that people don't, like, make these connections, heredity as well. I truly
Yeah.
believe that at some point we're gonna find out endometriosis does have a genetic trigger. It's gonna happen at
Mhm.
some point. We've mapped the genes, we've done all that already, but
Yeah.
we have to put the money behind the research to find what that process is.
Yes.
So that's just
Yeah.
my gestalt about the whole thing. I think there's gonna be a genetic component of this, and we know that there are gene therapies that do work for other conditions. These are things that are being explored.
Yeah, who knows how many other women in my bloodline have dealt with
Mhm,
this and just never knew about it or was just told that it was normal. It's really, really crazy to think about. And yeah, I mean, and we're all coming up on the end here, but I mean, we've talked about so many amazing things today. I'm sure that a lot of people listening learned a whole lot of new
I hope
information.
so.
Obviously, yes, obviously you're, located with Elysara in New York. For people listening who maybe aren't in New York or anywhere nearby and they're like, well, what can I do with all this
Yeah,
information? I guess,
exactly.
yeah, what do you have simple next steps for people?
So, I think number one, I would say see if you can find, and there are registries for this. Find a board certified, fellowship trained excision surgeon and meet with them and find out about their outcomes. I think that so like if you can't come to us, if you're in California or you're, in Colorado or whatever, and just so you know too, like we are trying to put together a network of surgeons nationwide that we trust that we can refer patients to. Because here's the other thing too, we have patients that we care for in New York, they have surgery in New York, and then they go and move back home. So
Mhm.
then so then how do we care for them? So then we're trying to find other providers that we trust that we could say, okay, we're going to hand you off now,
Yes.
to this other
Yeah.
person. And working through licensing issues and stuff like that, for telehealth and all of that. So we try to spread ourselves as thin as possible where that's concerned.
Yeah.
But I think number one is definitely get the right studies from an excision surgeon. I think that's number one. Number two, look for a provider that is comfortable with hormones and is also comfortable with understanding things like the inflammatory cascade, like all of these kind of nuanced things, and some functional medicine practices are very good at that. Others maybe, more so or not, but find one that says, oh, yeah, 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 that makes sense to me because we do this all the time. And you'll hear it in their voice. If they say, well, we don't really treat endo, but, we could still do an IV infusion on you for, a Myers cocktail or something like that. That's not
Right.
really the level of what we're talking about. We do really very therapeutic, very high level infusions on patients, but we also do things really off the beaten path, like procaine, doing N-acetylcysteine. We do LDN. We do there's a lot of things that we do that are highly specialized that most places are not going to do. So, we even tell patients like, hey, if you find a place that you trust, we'll talk them through it,
Mhm.
and try to get them, up to speed on the care that you need.
Yeah. That's
So
amazing.
it's even sometimes I tell patients it's worth a phone call. Even if you're out of state, we can still do coaching. Coaching applies to all 50 states. Licensing for medicine, obviously, I can't see patients in all 50 states because I'm not licensed in all 50.
Mhm.
Although I'm pretty sure my practice would like it if it was. But we still talk to patients and we coach them. And if they are in New York, even if they're not living in New York, but they're in New York at that time, we do see them and then we can at least help them through the process. And I think that's really important. I think make sure you get labs that show not just the regular things. Advocate for getting MTHFR tested, advocate for getting the inflammatory markers, which is like the interleukins and things like that, advocate for the hormone panel. Even if you're young, they're like, well, we don't have to test your hormones. You're young. Yeah, you do. You still have to.
That's yeah, what is I hate the "you're young" thing. What does that
That means
even
nothing.
mean? Like
Also, when you get imaging done, if you get an ultrasound or you get an MRI, can somebody interpret that through the lens of endometriosis, which is specialized?
Mhm.
So that's the other thing. We see a lot of underdiagnosis on MRIs when patients come to us from other places and they have their imaging and we see that they're underread, especially when cases of like adenomyosis and stuff like that. Um, like, oh, you have a fibroid. And it's just like, yes. Okay.
Well,
Yeah.
halfway
But
there.
it like it, so things like that, that I feel like are kind of underread. But making sure that you can find somebody that's willing to look at that and compare it then to your ultrasound and your labs and your symptoms and everything. And even if they can't handle it themselves, then that I would hope that provider would say, I'm going to make some phone calls and see if we can refer you to somebody who can do it if I can't do it. And that's and I put myself in that same bucket and everybody in medicine should. We don't know all things about all things. We don't. You have to put a governor on yourself and understand like this is my lane, but I'm going to take this as far as I can go. And if this is as far as I go, I have to hand this off to somebody else. And we do that all the time,
Yes.
and that is also important. So not that I want people to go doctor chasing and stuff, but if I really truly feel there is something else happening that we can't handle, I'm going to make sure that patient gets to the appropriate, especially for the patients with cardiovascular issues and endometriosis. That's huge. And also Ehlers-Danlos
Mhm.
neurovascular complications. We have tons of patients that have endo, Ehlers-Danlos, and MCAS, like all at the
Mhm.
same time.
Holy Trinity. Yep.
So I think that's what I would try to tell patients that, yeah, you could always reach out to us. We can go through a coaching to point you in the right direction if we can't legally see you for medicine in New York. So, we welcome people to do that. And then if
Amazing.
you have, a provider that you trust that is interested in doing what we do, then we would like to have a phone call with them too, and say, okay, like, this is how we are working through this process right now. Are you willing to do the same? So I'm hoping that there's more of that,
Yes.
keeping my fingers crossed that we're going to see more of that activity, as time moves on.
Yeah. And that's amazing. And, for everyone listening, I will make sure that all of Elysara's information and Jessica's information is in the show notes for you guys so you have easy access to all of that. I do have one last question for you that I like to ask all of my guests at the end. If you could rewrite the health class curriculum that every woman deserves, what would your first lesson be?
Ooh, first lesson. Don't take no for an answer.
I love that. That's
Don't
great.
take no
I love
don't take
that.
no for an answer. If something is wrong, don't take no for an answer. And this concept, people say, "I know my body." But yeah, you know what's happening inside your body. If something doesn't feel right, you know something's not right. So when somebody says to you, "Your labs are normal, everything is fine, you have a painful period, go away." Don't take no for an answer. Okay, don't accept that.
Mhm.
Don't accept that that's just the way it is. I wish there's so many people who grew up in the kind of mindset that, the doctor is always right, so they don't question. I think it's high time that we question everything because you're in a partnership with your providers. You know, they have to listen to you. I have to listen to my patients what they tell me. Sometimes I have to say to them, "Okay, now you got to pump the brakes a little bit. Now you got to listen to me." You know,
Right.
works both ways, but you have to
Yes.
be able to have that conversation. And even if I say, oh no, I'm never going to say that's a silly question. Why would you ask that? You should ask that because I can miss something too, like I like to think I'm thorough, but you know what? Again, we're not 100%. If you don't take no for an answer, you're going to minimize your exposure to being gaslit and being thrown out of the office.
Yes. Yeah, that's amazing advice. And I think for women in particular, it's something that a lot of us need to hear because, yeah, like you said, a lot of us are raised with that idea that the doctor's always right. But, we also have to accept that they are human
Mhm.
beings as well. And then also, just as young girls, we are raised to not be difficult and not take up
Be
space. And
slower, be
so if
quieter.
the doctor's like, right, it's normal, don't worry about it, you're just expected to be like, okay, cool. If you push back against that at all, you're immediately, like,
You're labeled
labeled as a
aggressive,
difficult
you're
woman.
yeah, all kinds of things.
Mhm.
Crazy.
Yeah. Yes. So but yeah, you just gotta tunnel vision, don't focus on any of that, just don't take no for an answer. I think that's amazing
Yeah,
advice
and
and
it's
would
okay.
take us
Yeah,
far.
and it's okay to call out a provider, when they're inappropriate. I think that's the other thing. People are afraid to do that, but if they are spoken to in a way that seems offensive or anything or just something's not right, you have permission to call them out on it and to do something about it. We hear this a lot where women have these issues. We hear these horror stories about these conversations that they have and everything, and they're just so mortified they don't say anything. When you hear something that is that uncomfortable, that is targeted towards you, do something about it. You know what I mean? It's the squeaky
Yes.
wheel that gets the oil. And like I said, we've been taught to be smaller, to be quieter, to be kind of fading into the background. And that is not working for us.
It is not.
Not at
Definitely
all.
not. Yeah.
Not at all.
Yeah, it's time to push back a little bit,
A lot of it.
absolutely.
Yeah.
Yeah, a lot of it. This was such an amazing conversation, Jessica. I know that so many people are gonna get so much out
I
of
hope so.
this. Yeah, definitely. And for everyone listening, make sure, like I said, check out the show notes, check out all of, the stuff that Elysara is doing. It's really amazing. And make sure you follow the show because we do have more episodes coming out in this series. And as I said in the beginning, you can check out the first two episodes with Nicoletta and the second one with Dr. George. We have really already in just 3 episodes, we've really hit this disease from a lot of different
Hmm.
angles. So I'm very excited for the rest of them. Thank you guys so much for listening and class dismissed.